Hello, everyone. I did my project on the use of a mucositis screening tool in pediatric oncology patients. The purpose of this evidence-based practice project proposal was to determine if a standardized mucositis screening tool compared to the use of no tool resulted in better management of mucositis in pediatric oncology patients. Next, I will go into my literature review that I did for the project. For a search strategy, I searched CINHAL, PubMed, Nursing and Allied Health Collection on Gale OneFile. For keywords, I searched mucositis assessment, pediatric or child or adolescent or Children's International Mucositis Evaluation Scale, and grading tool or scale. And I did this search from April to June 2024. For the significance of the issue of mucositis in the pediatric oncology population, it's notable that mucositis can cause pain, it can cause decreased nutrition intake, and overall increases patients' risk for infection and complication during chemotherapy due to the its open wounds in the mouth. And it can also delay further treatment if it's bad enough. There are tools that are routinely used in the adult population that are standardized and have been validated and proven effective to assess mucositis, but these tools often lack the nuance needed to assess children of different ages and developmental abilities, making this an important issue to look at for the pediatric population specifically. Next, I'll get into the description of the literature that I found. One thing to note before I go into it is the pediatric tools. There seems to be less, more current information about these tools, and actually, a lot of the more current tools did reference these older studies. So it's just something to make note of, that a couple of these studies are out of date of what you would typically want to use for the proposals, but I think that the information that they provide is still relevant. The first study that I looked at was the validation of the OMAS tool in the pediatric population. That's a tool that was used to assess mucositis in the adult population. Researchers used a double-blind trial to determine if vitamin E was effective on mucositis management, and part of the study looking at the vitamin E, they were able to determine that the tool was validated for the pediatric population as well. The next study that I looked at was the validation of the Children's International Mucositis Evaluation Tool, or the CHIMES tool. This was a quantitative quasi-experimental study that included children from 0 to 18 years old receiving stem cell transplant chemotherapy. Part of this study, parents and caregivers completed the CHIMES tool on standardized days throughout treatment, and they compared results to other tools, one of which was the OMAS, to determine that the tool was valid for patients 12 and plus. They felt very confident, and they said it was likely valid for patients 8 through 12. This highlights a theme that I found throughout all of the studies, that it's a little more difficult to find one scale to use for all kids, because different kids at different developmental abilities require some tailoring. On that note, these two next studies are newer studies that are done off of these older studies. The first one is the validation of the CHIMES tool by proxy for medical staff. So this study looked at a medical staff performing the CHIMES tool, assessing their patients, because they noticed that there was no literature for the use of proxy by medical staff, only by parents or guardians. They utilized data that was already collected during a randomized control style, where the CHIMES was used, and they found that this tool was reliable and valid when used by the medical staff as well. And then lastly, the validation of the proxy SSPD scale and mini SSPD scale. The CHIMES tool is actually part of the SSPD scale. The SSPD scale is a larger scale that looks at partially mucositis, but also some other side effects from chemotherapy. These researchers noted gaps in tools for children under 8 years old, which also seems to be a common theme in the literature, which could possibly be because once kids are older than 8, it's a little bit easier to use these adult tools because they function more similarly to adults cognitively. But these researchers were able to find that the SS Mini PD, which is they just made some adjustments to the SSPD scale, was reliable for children to complete 6 years and older. And they recommended a proxy tool for any ages younger than 6 to get the best results. So for my proposed change or intervention, based on all this research, is to implement the use of a standardized mucositis grading tool in the routine assessment of pediatric oncology patients. This proposed change should really offer little harm to patients as it only serves to gather more information. It's an assessment tool, and the standard of care wouldn't change of what the patients were getting before or after this tool was used. For the evidence-based practice model, I based this study off the Iowa model revised, and for the steps to follow to do the project. So these are the following steps that I followed to gather my information and propose this project. So first, I identified the problem and then stated the purpose of the project. Then next, you assemble a team and do the literature review. Once you've done the literature review, you determine if there's enough evidence to make a practice change. Then you design a pilot study, and then after the pilot study is done, you assess the results, and then also very importantly, you disseminate your findings. For project methodology, first, the inclusion-exclusion criteria I used for this proposal is pediatric oncology patients from 6 months to 18 years old receiving IV chemotherapy that requires some length of inpatient admission. And I would want them to have started chemotherapy within 5 days of starting this pilot. For exclusion criteria, I would exclude any patients that are in exclusively outpatient chemotherapy regimens or any patients that require an ICU stay during their admission for the chemotherapy. For a recruitment method, parents, guardians, and patients would be offered opportunities to participate in this study when they're admitted for inpatient chemotherapy or at clinic appointments prior to their chemo inpatient stays. And the type of sample used would be a convenience sample. For the data collection method, for the pilot, we would conduct CHIMES tools daily as part of our daily assessment and keep track of the data. The setting for this proposal is a large pediatric teaching hospital located in the Northeast, and it would be across the 3 inpatient oncology units in the hospital. For ethical considerations, any study that involves a vulnerable population like children, you always have to use caution and make sure that you're being careful with them. This study, patients should receive the same standard of care at minimum before the assessment is done. So it really shouldn't pose very much harm to these patients. For the outcomes, things that we would measure for the outcomes, the first would be infection rates. Mucositis can increase chance for infections because patients have open wounds in their mouth and down their whole GI tract, which is a source for a possible infection. So to monitor this outcome, we would track bloodstream infections on all the patients a part of the study and compare them to the data during the study and then before the study as well. This data should be available through charting because it's a reportable number, a bloodstream infection. And then for pain, that's another outcome that I would measure to determine if this project was successful. I would compare pain scores, which a pain score is part of the CHIME assessment. So that would be already built into the project assessment. Also, patients should be routinely getting pain scores on previous admissions and chemotherapy administration so that you could compare the data that you're getting during the TRAM score to data from other times. And then also you could track the amount of opioid pain medication that was needed during and after the treatment of the chemotherapy. As far as reliability and validity goes, the data and outcomes, like I said, would be compared before and after the tool is used through some chart review. And then you could use statistics to determine if your numbers are significant. For the significance to the field of nursing, this could be important for nurses because it really would be a nurse-driven assessment tool that standardized practice and language among nurses across the places that they're used. It can help nurses advocate for their patients better. And like I said, standardize just the language between nurses and providers and nurse to nurse and nurses to parents. It can also help potentially improve the quality of life for these patients. Because if mucositis is better management, there should be hopefully there's less pain and better pain management, which can help with things like nutrition and just overall better well-being for these patients while they go through the chemotherapy. And then lastly, it can also hopefully improve safety for these patients by decreasing infection risk. These are my references that I used for the project. And that is it. Thank you, everybody, for listening.